to the FLaNET community. We are joined by my colleague, Dr. El-Haddad, who will be having a discussion with us about liver-directed therapies and radiotherapies for the treatment of neuroendocrine tumors. He wears both hats within our team, and through his leadership and efforts, Moffitt Cancer Center is a center of excellence as designated by the Society of Nuclear Medicine and Molecular Imaging. So we're very thankful for your leadership. So to start, because both topics we're discussing are quite different, can we start by you explaining the general concept of liver-directed therapy through interventional radiology, and then we'll go on to PRT, and then we'll discuss them more in detail. I want to remind everyone, if you have a question, please raise your hand on your app or unmute, and please join within the conversation. Tamia Al-Tauba will be helping us know if you have a question.
Thank you, Dr. Hayler, and thank you everybody for logging in and joining us this afternoon. So as you said, I do both liver-directed therapy and as part of interventional radiology, and also radiopharmaceutical therapies within nuclear medicine. So with regards to liver-directed therapies for metastatic neuroendocrine tumors, we know based on data that you want to try to control the disease in the liver as much as possible, because patients who have liver metastasis, that is the most important location or organ as far as survival. So we want to try as much as possible to control the disease in the liver. Usually patients, if they can be surgical candidates, they will get surgery, but most patients, they cannot get surgery, or during their disease, they become non-surgical candidates. So what we do is liver-directed therapies to try to control these tumors in the liver, and to do things that the surgeons cannot do, or if the patients are not really surgical candidates. So within liver-directed therapies, we have kind of two major branches. Number one is the ablations or percutaneous ablations. We use image guidance to put special probes inside the liver. Usually we use heat to burn these lesions, whether it's radiofrequency ablation or microwave ablation. We use ultrasound or CT scan to target these tumors in the liver with special probes, and we try to burn them, basically. And that is limited by the size of the lesion. So if you have lesions that are 3 centimeters or smaller, and depending on the location, we are able to do that. And for certain sizes, less than 3 centimeters, less than 2 centimeters, we can get very good results. And it's almost like doing mini surgeries where we can get rid of these lesions. And that can get pretty good control of the tumors in the liver. The other branch of liver-directed therapies is intra-arterial therapies, meaning we go when you have multiple lesions now that you cannot target with one ablation, 2 or 3. If you have multiple lesions in both lobes of the liver, then you need something that is more generalized to the liver. And we perform intra-arterial therapies. We go from the groin or from the wrist, inside the blood vessels, inside the hepatic arteries, into the liver. And we inject contrast to determine where the lesions are mostly located, and inject small beads that go in and treat the tumors. Now, what type of beads do we use? That's another kind of subdivision into the intra-arterial therapies. There are different types of beads that we inject. We have first what we call bland embolization, meaning small plastic particles that we inject, and they go inside the blood vessels. They concentrate where the tumors are, because usually neuroendocrine tumors are very vascular, meaning they take more blood flow than the surrounding normal liver. And then we use that to our advantage or against the tumors. So we go inside the liver and we start delivering those beads, and the beads preferentially go where the tumor is, and they cut off the blood supply or decrease the blood flow to the tumors. That is called bland embolization. The other type of embolization is called chemoembolization. Usually the one indicated for neuroendocrine tumor is kind of liquid chemo that we mix with a special contrast. It's the lipiodol. It's an iodinated poppy seed oil. It makes an emulsion that we inject in the liver, and that goes and penetrates into the tumor to bathe the tumors with chemotherapy. And then we follow that with the bland embolization, small particles, again, to slow the flow to the tumor. So it's a kind of a combination. It's a bland, it has the bland part, but it also adds the chemotherapy part. The third one is the radioembolization. Now you have small particles that are smaller than the ones that we use for bland or chemoembolization, and they do not cause a ischemia or decrease oxygenation to the tumors, because with radiation you need oxygen to have the effect of radiation. These are much smaller beads that we inject into the tumor, into the liver, and then they also concentrate in the tumors, and they cause their damage to the tumors by emitting radiation. Now, if you ask me, how do we choose, or what, is there one that is better than the others? We tend to leave usually radioembolization, the radiation beads, for either rapidly progressing tumors in the liver or highly aggressive tumors, or in tumors that stopped responding to the bland or the chemoembolization. And that works pretty well. Or if we inject it sometimes in a small area at high dose, where we can also cause kind of destruction to that area, similar to what an ablation would do. But we don't usually use it as a first-line embolization, because similar to how it's very potent and can destroy the tumors, it also leaves potentially more side effect in the normal liver. And here, as we say in neuroendocrine tumors in general, this is more of a marathon, not a sprint. So we want to do whatever we can to keep the tumors under control for the longest period of time. So we always weigh in the benefits of the therapy and the potential side effects. So we want to do radioembolization. It's indicated in certain areas. And then even when we inject the radiation, we will go through a lot of calculations and to try to determine what is safe to inject. So the two most common that people know about are the bland embolization and chemoembolization. There are really not yet, at least, no trials that showed a benefit of one versus the other. We have a trial called the FLaNET trial that is comparing both bland embolization to chemoembolization. Possibly after December, we will have maybe some results of, at least early results of the trial, which is a multinational, multi-center trial trying to compare the two. And we may have the answer as far as which therapy may have more benefit, or if they are equal. We know for example, in liver cancer, different type of cancer, they are not significantly different, the bland versus the chemoembolization. So usually it's institutional preference what you use, whether you use bland embolization or chemoembolization. So that's kind of in summary what we do for liver-directed therapies.
Well, if we delve a bit deeper, so we routinely treat patients and serve patients together, and so I want to highlight that liver-directed therapy can still be used in the setting of otherwise metastatic disease. So, for example, one can still have lymph nodes outside of the liver present, But I view liver-directed therapy as effective for liver-dominant change, meaning we have reviewed scans together and we see that there is a change in growth pattern limited to what's in the liver, and we might continue the backbone of treatment to treat the entire bodies, many times in the form of a somatostatin analog, but layer on this treatment. And then we also, as you said, want to see vascularity because that's where we can have the most effect. So we may not always offer liver-directed therapy if we don't feel like that mechanism is there.
Correct.
And then I think I want to re-highlight your discussion that liver-directed therapy is not limited to only low-grade tumors, because we look at, for example, radioembolization for perhaps a more aggressive type tumor where that's more suitable. And can you speak, when we go on to talk about PRT, we might talk about lifetime exposure, but for embolization, we're not limited to a one-time treatment. So in your view, once you have treated a patient with an embolization, what is seen to be a successful timeline of response such that you may reuse it at next progression?
Yes. So you're right. As far as how many times we can use the embolization, and for radioembolization, it's a little bit different. We sometimes may be limited by how much radiation we injected and how much the normal liver received. And if you do bilobar disease, you treat the whole liver, you may not be able to use it more than 2 times, possibly 3. But if you're doing it very selectively in very small areas of the liver, you can use it multiple times. With bland or chemoembolization, there is no number of treatments that you use. As long as the liver function is still normal, we don't have any damage to the liver. As long as we've had indication of response, for example, then because we're not going to repeat a therapy that we know it has not really worked very well. So what is a successful embolization? So the number on how long you can control the tumor varies, but on average, I would say usually with bland embolization, if I would consider a successful embolization if it's around a year of tumor control. So let's say a year to sometimes a year and a half. I've had patients that had more than 2 years of control. So it varies. But if I've treated patients that after 3 months, the tumors that maybe initially had responded started progressing again. So we know that this type of embolization is not going to be good for them, and we would not continuing it. But as far as numbers, let's say every 2 years, there's a little bit of progression, we can repeat it. As long as the liver is tolerating, we don't have too many side effects that can happen if you do it, somewhat conservatively. Of course, if you do it very aggressive, anything we do inject in the liver can lead to side effect. So you have to always pay attention how you're doing these procedures, because we always think about how we're going to preserve the normal liver when we're doing the treatment. We don't just focus on controlling the tumors, because you have to think of on the long term how your therapy is going to affect the outcome.
And certainly, we want to look at the patient as a whole and the background liver function. Absolutely.
Definitely. And so just a parenthesis here, because you mentioned exactly that's something very important that we have to, when we do discuss these therapies, of course we discuss them with the patient and describe what they entail, and then we didn't discuss that, but there is a little bit of difference, for example, on how the patient feel after the therapies. And other than controlling the tumors and their growth in the liver, we also do these liver-directed therapies for hormonal secretions, patients who have carcinoid syndrome, shortness of breath, flushing, diarrhea. And the response to liver-directed therapy can be extremely helpful with these. When we do embolization, up to 80% of the patients can have improvement in their quality of life and in control of these symptoms. So that's an important thing. But with embolization, whether it's a bland or chemoembolization, we discussed that you may have acute side effect of maybe abdominal pain or low grade fever or fatigue. And those are, the side effects are usually the first couple of days. So we have to admit patients in the hospital at least, usually one night in the hospital to give IV pain medication, anti-nausea medication, antibiotics to prevent any infection in the liver. And then they go home with oral medication. Radioembolization is different. It's done all outpatient. The effect is most patients do not feel the direct effect of the treatment, so less pain, but the fatigue is more common, and it starts a little bit later and lasts maybe longer, about 2 weeks. So I just wanted to mention that.
Yeah.
We have a question in the chat box. Can this treatment be used in the pancreas? Well, we treat pancreatic metastasis into the liver, but as far as treating the tumor in the pancreas itself, as far as ablation, we cannot use an ablation of the pancreatic tumor because the current ablation techniques that we have, whether it's microwave ablation, cryoablation, so freezing the tumor, burning the tumor, they cause a lot of inflammation in the pancreas, and the pancreas, if it gets inflamed, pancreatitis can be extremely severe and very dangerous and can be life-threatening because the enzymes that the pancreas usually secretes in the digestive tract to digest food now goes outside of the pancreas, and it causes a lot of damages in the tissue around the pancreas. Embolization, going inside the blood vessels that supply the liver and injecting beads to cut off the blood supply to the tumors to do the same thing that we do in the liver, is not technically as feasible in the pancreas compared to the liver, because there are so many blood vessels going into the pancreas that feed the tumors. Plus, when we inject the beads, it is hard to limit the beads to go only to the tumor. And that's why some of the beads may end up going to the stomach or going to the bowel. And that's why, in addition to the risks of inflammation, it is not technically feasible. And there are no studies showing that there's any benefit in doing these procedures to the pancreas itself. Now, maybe in the future, there may be other types of ablation techniques that might be effective here, and we can mention that later. But at least for now, we do not have the techniques that can do that.
Thank you. So to recap, you brought up a great point that this treatment is not limited to growing tumors, but also symptomatic or tumors that are resulting in a hormonal syndrome, and we can palliate symptoms as well. Mm-hmm. So one must not have experienced growth, but we can treat symptoms.
Correct.
So, and thank you for reviewing the patient experience. So we do counsel that if we're planning a bland embolization, an overnight stay, because we're causing a new source of pain that can be better treated in hospital, and usually our patients are leaving within the day. And at home, can you speak a little bit about, a little bit more in detail about the patient experience with flu-like symptoms and what is anticipated and that timeline?
So as far as, let's say, bland embolization is what we use most commonly, at least here at Moffitt. So the most common immediate side effect, there are some that can happen during the procedure. So when we deliver the beads, within sometimes seconds, what can happen is that these tumors that a lot of them secrete hormones, they can release vasoactive peptides and hormones into the bloodstream quickly while we're doing the procedure. And that can sometimes happen by injecting only the contrast into the liver. It's what some people call it the carcinoid crisis, or it's not really crisis, hemodynamic instability. So what happens with the release of these hormones in the blood? You can have an increase in the heart rate, you can have increase in the blood pressure, sometimes a decrease in the blood pressure. And that can happen also with other types of procedures. Surgery, in patients who get surgery, they can have this with anesthesia, with PRRT, with different types of treatments. Whenever you kind of trigger these tumors or destabilize them, there is release of vasoactive peptides and hormones in the blood, and that can cause these reactions. So that is kind of the most immediate reaction to embolization, and we have a protocol, usually an algorithm of, because we have to expect this, and the nurses know this, and that's one of the most important, because they have to act quickly. So you're doing the embolization, like I said, it causes most commonly pain, but then you have patients that have started having pain from the embolization. Their heart rate is going up, their blood pressure going up. So we have to be very quick in trying to control the pain, control the blood pressure, control heart rate, and we can use different medication to do that. Most common, and then we also administer octreotide, kind of short acting, to try to mitigate these reactions. Usually with these, and of course we've given them octreotide before the procedure, and we give them for a day after while they're staying in the hospital. Usually with all these medication, we can control this hemodynamic instability. Rarely we have to put patients on, a drip, but usually that's within 24 hours. So and then the abdominal pain can happen. Usually it starts with the first embolization. So patients who are not used to, have not had an embolization before, the first time you do it, of course, the body is not used to that. And we usually start with the lobe that has the largest amount of tumors, which usually is the right lobe, because the right lobe is bigger than the left. So normally you will have more tumors, usually more than the left. So when we start treating the right side, patient, usually the first embolization may have more symptoms than the second time around, because it's a smaller volume when we do it the second time, and they're a little bit more used to it. So the abdominal pain, nausea, vomiting can happen. Flu-like symptoms, low-grade fever possible. The fatigue can, sometimes last 1 week, 2 weeks. Rarely I've had patients that had the fatigue lasting for almost a month, which would be the time for us to do the other embolization. So like I mentioned in the beginning, I may have mentioned that we don't do the whole treatment, the whole embolization all at once. So we don't do the whole liver, because we want to make sure that there is a normal part, there is a part of the liver that remains functioning and is not affected by the embolization, so we don't have a complete liver failure if there is any side effect. So we treat, for example, the right lobe, wait 4 to 6 weeks, let the liver recover, let the patient, feel themselves again, strong enough to undergo the second procedure, and then we go in and then treat the other part of the liver. Mm-hmm. So we have to give some time for the body to recover before we do the other side.
Thank you. We have a question. When should debulking surgery be used for the liver? I think at the top of the hour, we talked about that we look at every care together as a team, and if surgery can be offered, that is what we go for. So that surgery is deemed feasible by reviewing the distribution of disease, how much liver can be maintained after surgery to support well-being. And we want to feel confident that we can debulk, which is remove at least 70% of the tumor burden, to have a successful outcome that serves one's overall well-being and course. So if we can't achieve that, or sometimes, surgery is technically feasible, but our patient is not healthy enough for that kind of procedure, and then we can introduce liver-directed therapy there. But we do try to make these decisions together, such that surgery has insight and provides that option if we can do it.
Absolutely, yeah. We're not saying that these liver-directed therapies that we're doing are a replacement for surgery. Obviously, if the patients can get the surgery, if they are surgical candidates for their performance status, or if the lesions are in a location where they can remove them, or as you said, sometimes the remaining liver that is going to be there after they remove part of the liver with surgery is not going to be enough. So then there will not be surgical candidates. And we do work very closely with the surgeons. And one of the procedures that we do, I did not include it here, as a therapy for the liver, but it's kind of also a liver-directed therapy, is called portal vein embolization. So the liver gets a dual blood supply. It gets about 25% of the blood supply from the hepatic arteries, and the rest, 75%, is from the portal vein. So most of the blood flow is going from the portal vein. But the tumors, they get all their blood supply from the hepatic arteries. And when we do these liver-directed therapies, we go in the hepatic arteries and deliver our treatment. But if, for example, a patient is a surgical candidate, however, if the surgeon is going to remove a large part of the liver and what is remaining is too small, is not going to be able to function enough and to do the function that it's supposed to do, what we sometimes have to do before the surgery is that we go percutaneously through the skin into the portal vein, either right side, left side, usually the right side, because as I mentioned before, the left side is usually the smaller. So if you want to grow the left, we go on the right side, block the flow that is going, most of the flow that goes to the right lobe, and divert it to the left. And within weeks, you can have the left lobe grow enough for the patient to get the surgery, and then the surgeon can go in and resect the right lobe. So that's one of the things that we work in close collaboration with the surgeon to make sometimes patients that are not surgical candidates become surgical candidates, because it's still that we think that would be the most helpful for the patients if we can do it.
Mm-hmm. So that's it, preparing to make surgery an option in that setting. Thank you for your question, Ms. Tolbert. We, in a previous webinar, touched upon histotripsy, which is kind of new, or within our clinical practice off trial. Can you introduce that topic and briefly comment?
Yes, there has been a lot of talks about histotripsy and interest about histotripsy, mostly coming from the patients, to be honest, asking about this new therapy. So I mentioned before the current types of ablations that we do are heat-based or cold-based or electrical-based. So we have microwave or radio frequency ablation. They raise the temperature, where we put in different mechanisms. We put the special probe inside and then increase the temperature around where the probe is, and then burn the tumor and the small surrounding margin. Or we can freeze, which is called cryoablation, freezing the area. Irreversible electroporation, sending electrical shocks basically into that area to cause cancer cell death. And so we have electrical, cold, heat. Histotripsy uses none of that. It's non-ionic, so there's no radiation, and there is no it's not thermal based, so there is no changes in the temperature usually. And what it does, it sends kind of focused ultrasound into a small area, and that is usually sent by a machine outside of the patient. So there's no puncture, there's no incision. It's not really invasive. It's almost like a radiation therapy that's sent from the outside, but here we're sending sound. But focus in one area to create what we call cavitation. There are small bubbles that get created in that spot, and the goal is, again, same thing, to kill the tumor. Or what happens is sort of liquefaction. It becomes like just a liquid where the tumor was. So that just had received FDA approval, I think within this month in October, based on a trial called Hope for Liver. Initially, there was a Teresa trial done in Spain on 8 patients, and then the Hope for Liver trial. It looked at the safety and efficacy. So we don't really have strong data, to be honest. I have to be very transparent about this regarding histotrypsy. So the only thing we know is that it was tested on 44 patients doing this for the liver, and it was determined to be safe. The side effects were very small, and that it was efficacious. Now, here we have to pay attention, like how efficient it was. The patients that were included a very heterogeneous group. So patients with primary liver cancer, metastatic colon cancer, metastatic breast cancer. I'm not sure how many patients with neuroendocrine tumors were within those 44, to see how well it works for these types of tumors. So we still have a lot of things unanswered for histotrypsy. I'm sure that this is going to become more kind of mainstream in the near future, but we do not have still major strong data to help guide us how well it is, especially for neuroendocrine tumors. Now, one of the things that they hope they can get from histotrypsy that is not, in addition to the ablation itself, the mechanism of ablation, because it causes liquefaction of the tumor, and it doesn't cause too much inflammatory reaction, but the release of the antigens from the tumor in the blood. The theory is that maybe we can combine that with immunotherapy to have a better response to immunotherapy, almost making the auto-vaccination. So you release a small amounts of antigens from the tumors in the blood to stimulate the immune system, combine it with immunotherapy, and you hope that you're going to get a response. But this is still all theoretical, just based on how the procedure is done. Now, unfortunately, I mean, most patients with neuroendocrine tumors do not really respond well to immunotherapy, as you probably know much better than me on that subject.
Yes, well, I think what you're highlighting is combination. So we don't, the future direction is combining modalities together synergistically to increase power against the tumor control or symptom control. But you are correct, just very briefly, immune therapy seems best suited for neuroendocrine carcinoma or very high-grade tumors, and does not seem to have benefit for low-grade tumors. Thank you for that explanation. I think that's going to be an ongoing discussion and kind of part of our tool set in the future, potentially. Before we move on to PRRT, I wanted to see if anyone has comments about experience with liver-directed therapy or questions, and we can circle back to questions, of course, at the end. Or if our colleague, Dr. Strasberg, has any comments based on these discussions, we welcome those as well. All right.
One thing I forgot to mention, because you asked about histotrypsy. One of the limitations of the therapy is going to be the location, because since it is ultrasound that we're going to be using, if the lesions are behind certain structures where you cannot really penetrate, let's say a rib, or lesions in the upper part of the liver, are going to be much harder to treat with histotrypsy than the lower part, because the upper part of the liver can be surrounded by lung, so it wraps around the liver, and air does not allow the ultrasound to penetrate. So, in general, yes, it's a great, it may become a great tool and for new treatments, but it's it still has its own technical limitations. You may not be able to use it for all tumors or for everybody.
Was there a question coming up? I heard unmute. All right, so shifting to your other role in treating patients, we want to focus on now on PRRT. And we have spent time talking about the mechanism of action in the past and have webinars uploaded for reference for that. But in general, my view is that this is radiotherapy, but it's really a systemic treatment, and we are addressing all tumor sites. And that's where I favor this if we have change in disease growth, both perhaps in the liver and also external to the liver. So I think where we can start is what type of tumor in which patient do we look at PRRT? So maybe we can start, with the use of a PET scan and what kind of PET scan and what we should be seeing there.
Yeah, so as you mentioned, PRRT, peptide receptor radionuclide therapy, is a systemic radiotherapy that is very targeted. So and it targets the somatostatin receptors that are overexpressed on the neuroendocrine tumors. And because it's targeted, we do not do the treatment without doing a scan to make sure the patient is a good candidate for it. So this is what we call the era of theranostics, meaning diagnostic part coupled with the therapy part, both looking for the same receptors, the somatostatin receptors. So you'll do either an octreoscan scan or a PET dotatate with different types of radioactive material. But the goal is to see if the tumors have the receptors or not. So we do the PET scan, let's say PET dotatate, and then we review the images and then see how much there is activity or radioactivity concentrating in those tumors. And there are some criteria that the diagnostic nuclear medicine physicians would use to determine whether a patient is a good candidate or not. But the higher the activity is actually better, because we know better for PRRT and better for patients in general, because we know that these therapies are going to concentrate more into these tumors. So the selection criteria, and then there are other things that we look at, the lab values, making sure that liver function is okay, kidney, etc. Overall performance status. So those are, for every type of therapy, we usually have to look at these. Mm-hmm. But for PRRT specifically, because it's targeted, the imaging part is extremely important. And we've had patients, for example, that we will scan. It's not very easy, to be honest, sometimes to look at these and determine whether all the lesions have the receptors needed. You could have multiple foci, multiple spots in the bone and the liver and some lymph nodes, etc. And even within the liver itself, there's a very large heterogeneity. So we've had patients, for example, that had one lesion that was not as hot, if you want, or did not concentrate the radiation as much as the others. So those tumors will not respond well. And when we're doing follow-up, we saw that other lesions are responding, but the one that did not really have enough receptors kept growing. And that's why the reviewing the images prior to therapy is very important. In addition, we look at certain things that we may consider as potential risks of the therapy, meaning where the lesions are in the abdomen. There are certain spots in the peritoneum or the mesentery, and how that interaction of the tumors with the bowel around them, that may sometimes increase the risk of some patients for example, bowel obstruction. So that is something that we also look at with the imaging, the potential risk that may happen with PRRT. And that's how we determine whether the patient is a good candidate or not. But in general, as you mentioned, this is usually patients who have multifocal disease, in the liver, outside of the liver. Now, have people used PRRT to treat liver-only disease? Probably. I'm sure a lot of places that they do that. If they do a scan and it has the receptors needed, they may give PRRT. this is not how we approach usually these patients, but it's possible, to do it, even if it's liver only. If we do liver directed therapy and it's not really working well, and you do want to do something else, you may also do, PRRT for those patients.
And this takes some unique education of how to manage post-treatment care at home. Can you speak about, just very briefly, the schedule and then what we are providing for education for patients after each treatment?
Right. So, the PRT is given as a schedule of 4 injections every 2 months. It's an infusion. The actual infusion of PRT takes about 30 minutes, but the whole kind of treatment is a little bit longer, takes 4 to 5 hours, because what we do is you have to inject, that's a very important part of the therapy, because we won't do it without it. We have to inject amino acids to protect the kidneys from excessive radiation. So that infusion of amino acid that we start before the PRRT is given. And then it also is given for 3 hours after the PRRT is also administered. It circulates in the body, and then, inside the kidneys, what it does, it doesn't allow the kidneys to reabsorb the radiation that has already been excreted. So that limits the amount of radiation that goes to the kidney, and that is, part of the treatment. But it also means, as with relation to your question, that there's some radiation that is going to go into the urine. So we give patients, after we give them PRRT, or even during the initial consultation, about the things, that guidelines about how they have to, the precautions they have to do when they go home with other family members. Most importantly is that to limit the close contact with pregnant women or young kids. Not because we know exactly what is going to happen if you hug a patient, if you just got PRRT. Usually the amount of radiation that is going to be exposed to other people is extremely low. And, me personally, I don't think, even if you hug somebody for 24 hours, nothing is going to happen. However, we use what we call the as low as reasonably achievable, meaning limit as much as possible the amount of radiation that is going to be or other people of the going to be exposed to. And the most sensitive population would be the young kids or pregnant women. But basic hygiene precautions for the first week, go to the bathroom, flushing the toilet twice, washing hands after, etc. Do not mix your toothbrush and with other people, etc. So very basic things that normally people should be doing anyways. Mm-hmm. But it is not, the people who get PRRT should not be afraid that they have to be isolated from other people for long periods of time. And it's really not indicated. There's no need for that. Mm-hmm. But usually the concerns about radiation and what to do after are the most common questions that we get when we do these therapies. We check labs between each treatment and make sure that the patient is still tolerating, because the radiation goes, yes, to the tumors, but some of the radiation can affect the bone marrow, the production of blood cells. So if we see a trend where the numbers are not going the right way, we may have to decrease the dose that we give the next time. We may have to hold the dose. We may have to stop the treatment completely. Liver usually tolerates it pretty well. Kidneys, unless patients have already an underlying kidney problem, they usually tolerate it pretty well.
Mm-hmm. Yes, and I think that even watching the bone marrow, which is the factory that makes our blood, over time after completing 4 treatments is part of the surveillance there. So we treat with 4 cycles that are 8 weeks apart. There's some experience with retreatment if one can achieve an excellent sustained control to revisit PRRT, although it might not be as effective the second time around. And we do have a clinical trial looking at that concept as well. Ms. Mason, I see your question and I'm going to answer it. But very briefly, because of time, Dr. El-Haddad, I feel that the PRRT as a concept is growing. Right now we use lutetium and the medication uses Lutathera. However, we've had clinical trials looking at other radiation emitters, which might be more precise or even a bit more advantageous in terms of tumor control. Can you comment on your view of the future?
Yeah, so with PRRT, you have kind of two components. You have the molecule that goes and attaches to the somatostatin receptors, and to that molecule, we have a radioactive material. And that could be, currently what we use is lutetium-177. It emits beta, what we call beta radiation. That radiation is what causes the cancer cells to die because it causes DNA breaks. But so in the future, there will be the changes that may happen is that this molecule, you may hear about new molecules that are a little bit more specific to certain receptors. And at the same time, we're also working with different types of radioactive material and looking at maybe different, instead of beta emission, there's alpha therapy that has things like actinium-225 or lead-212. These are different types of radioactive radionuclides. The alpha emission, the alpha particles are much heavier than the beta radiation. The energy that is delivered to the cancer cell is much higher. So you have, in theory, a much higher chance of causing the cell death.
Mm-hmm.
So that there are a lot of trials ongoing currently to see the benefits of alpha therapy, and whether we don't know when the sequencing, whether you do alpha first, beta after, beta first and alpha after for patients who are resistant, or you would use alpha from the beginning. We will also have to look at the side effect, that potential side effect, because as I mentioned, it's very efficient to kill the tumors, but if it circulates and it goes, we mentioned the bone marrow, there are salivary glands also that can have some uptake. If you do have side effects that are higher with these therapies, so you have to weigh the benefit and the potential side effects.
Mm-hmm.
So that's the, in general, the potential for new therapies with the alpha, but we still have to, know more about once the clinical trials are completed.
Mm-hmm. And they are ongoing. So to the question posed, in general, the question is after surgery, if margins, meaning, when we look at the specimen from surgery, it is not surrounded completely by normal tissue, and you can see tumor to the edge, signifying that perhaps there's tumor left within. Could we use PRT as a radiation option? And I think that brings it back to our view that first we need to have a PET scan that shows a target for the medication. I think you would agree with that, Dr. El-Haddad. And it's really
Yes.
viewed as a systemic therapy, meaning treating more than one area usually that is progressing, meaning it is growing. So here after surgery, Ms. Mason, we would not use PRT as the modality for radiation. And there are other discussions that we can have in clinic, after surgery, if there is a positive margin. And we're not limited to PRT in the realm of neuroendocrine tumor treatment. And that brings up your point that we have to be understanding in what particular situation do we serve best, and where are we increasing risk when we have several other options for medical treatment. So you mentioned, the location of tumor. Are we going to cause injury to bowel that is going to be a big side effect to deal with long term, when we could have used something else that did not offer that risk?
Yeah, so to answer this question, in general, we don't have yet any, data or studies done for the use of PRRT kind of preparation for surgery. Some people use it kind of, but we don't really know how much it helps the surgery before surgery, or even immediately after, if it's localized in one area. So because one of the things that with PRRT, most commonly after a treatment with PRRT, the tumors, they either stay the same size or shrink a little bit. It is not very common for the tumors to disappear. So that is something that people have to understand. Even the uptake, you may still see uptake if you repeat PET scans. So in order to do a debulking, you want to have a shrinkage of the tumors. The PRRT, at least with what we have currently with the lutetium, because you're limited with how much you can inject, it does not cause much of shrinkage of tumors, or what we call debulking. A localized area where there may be potential residual disease. Also, this is not one of the things that, an indication. Of course, all cases we will have to discuss in tumor board and then determine, whether we're going to use something that is a little bit off, not standard or not what we normally do. But this is not, in general, not used in this particular scenario. Even external beam radiation, we have to think about it, because as I mentioned before, there's always potential risk with whatever we do. So you have to weigh the risks and benefits. There was a question at the end whether we would use a chemotherapy for tumors that are not showing up on PET scan. Obviously, if they don't show on the PET scan, so PRRT is already canceled. And there are other therapies that could be used in patients where the tumors do not show on PET scan.
Oh, thank you so much for your question. We have a few minutes to wrap up, and I just want to pause and invite the audience if you have questions or shared experience.
Can I just talk?
Yes, absolutely. Please do.
Dr. El-Haddad is an excellent doctor, and he was the one who got me to do the Lutathera. And I probably wouldn't have done it if I hadn't spoke to him. And he also did my embolizations. So he's very good. And if he told you something, you really should listen.
Even as his colleague, I always listen when he tells me something too. But I agree, and I think what you're highlighting is his experience and the team experience here. Dr. El-Haddad and Dr. Strasberg were prominent in the clinical trial looking at Lutathera for evaluation here in the U.S. And so there's a history and eloquence to our team approach here because of that. Thank you so much for your
Thank you, Ms. Stolbert.
All right.
Any other comments? So I think, Dr. El-Haddad, what we highlighted today are really two of many treatments. And really, it wasn't enough time to delve into each really to its deserved depth. But overall, would you agree that our team approach is we can be quite personalized to the behavior of a tumor and its location in terms of symptoms and where it's changing in size to best decide how to sequence, either focus on the liver with liver-directed therapy or change kind of the backbone of treatment to a more systemic therapy like Lutathera?
Yes. So my approach is, exactly that. I really do not have a bias. That's how I feel, very comfortable when I look at the cases that are presented to me, because I look at the patient as a whole. we have a very wide range of possibilities, whether we can do ablation, embolization, which is better for the patient. And then sometimes I talk to the patient, and if they're 50-50, depending on how they feel, we just go with it. And to PRRT, and we didn't talk about sequencing also, sequencing of PRRT with other type of therapies. It can get a little bit complicated, but we always have to look at the patient as a whole, what they have received before, how we're gonna control the disease for the longest period of time possible, and then think about the future. What do I do now? I do not want it to prevent them from having any therapy in the future. That is, part of the discussions that we have that are usually very deep and complicated, and I'm very lucky to be able to work here at the institution and being able to talk to you, and Dr. Strasberg, and we have these discussions on daily basis pretty much.
Yes. Yes, and I think you can be quite personalized to each unique situation. And your point is very well taken, that we are looking to use a treatment at this particular time, but looking at the future timeline as well, so that it serves best to not be a hindrance to future treatments when we need to look at them. Well, I thank everyone for your time. We do still have 3 minutes. If there's a comment or a question, we would welcome that.
Do you have other videos that you might have on your portal to explain, like for, in my case, pancreatic nets, or like that you've uploaded like this?
Yes, well, one resource is the website for FLaNET, where we have, since our first meeting, uploaded our webinars and websites also, and that's a very good reference. You're welcome to also have even more information in clinic or a one-on-one discussion. And if there are particular questions via your patient portal, you can also send those and we can provide more information.
Thank you.
We also have an upcoming, our annual meeting that will be in person, where we encourage our patients and their families and support systems to join us. We're looking for this in the new year, and it will be in Miami. So please keep an eye out in your emails for that. We're very excited about putting this together for our community, and it will be on January 27th. And Ms. Mason, our webinar from in collaboration with a medical center in Jupiter had a large overview, and that's recorded for your reference. Thank you, Tamia, for bringing that up.
Great, thank you.
Thank you, everyone, for your time. Have a good weekend. Thank you so much, Dr. El-Haddad, for the discussion and joining us.
Thank you for moderating, and thank you, everybody.